Hello, everyone. Thank you for joining this session today. We're just bringing people into the waiting room, so just give it about one more minute here. Perfect. So I'll get things started. Good afternoon, everyone. My name is Jacqueline Robinson, and I am the clinical nurse specialist with the Post-COVID-19 Interdisciplinary Clinical Care Network, and I will be the moderator today. Welcome to today's session of the new year, Project ECHO for Post-COVID-19 Recovery. For those of you who are unaware, the Project ECHO is a virtual learning community of specialists and community healthcare providers, and we are using a combination of didactic and case-based learning to help improve care for patients recovering from COVID-19. And before I introduce our topic and speaker today, just a few housekeeping announcements. A brief disclosure, today's presentation will be an updated version of Dr. Jansen's previous presentation she did on July 13th last year. We thought it would be a really appropriate time to review the post-COVID-19 fundamentals of care and update you as you continue to care for patients in recovery. And so if you previously attended that first session in July, you will not receive the UBC CPD certificate for today. However, to track attendance of those who did not attend the previous session, we are asking you to put your first name and last name and email into the chat function, and we will issue your certificates. We will also have a question and answer period at the end of Dr. Jansen's presentation today. We want this to be as participatory as possible as we learn together. Please use your raise hand function on your Zoom screen, or feel free to type your questions into the chat throughout the presentation, or at the end, we will review those. And without further ado, I consider it a great honor to introduce our speaker today, Dr. Renee Jansen. Dr. Jansen is a general internist who practices at St. Paul's Hospital and BC Women's Hospital. Her interests include addiction medicine, central sensitization syndromes, and medical education. She is an attending physician on both the clinical teaching unit as well as the addiction medicine consult team services at St. Paul's Hospital. She also provides care for patients with fibromyalgia, chronic fatigue syndrome, and other similar disorders at the Complex Chronic Disease Program at BC Women's Hospital. She has also provided care for patients at the Post-COVID Recovery Clinic at St. Paul's Hospital, and we are grateful that she's here today to speak with us. I will now pass it over to you, Dr. Jansen.
Thanks. Okay, hello everyone. Thanks for joining over your lunch hour, if you're taking lunch, that is, I guess. So yes, this is an update to the talk I gave in July, and I'm sad to say that really there isn't much more to report, or not much in the way of updates, I guess. Yes, let's get started here. So firstly, I have no disclosures or conflicts of interest. This is also, as seen on the website, essentially we'll just do a bit of an overview of long COVID. What is long COVID? An approach to the basic workup of individuals presenting with symptoms characteristic of long COVID, and to kind of tease apart who might be those patients that you would want to send on for further investigations or to see other specialists. The last time I didn't talk at all about treatment. This time I will touch on it briefly, because I think it's just sort of helpful to kind of have a brief overview. Because there are treatments, although as you know, not many. So just kind of, I guess, taking stock of where we came from. Obviously, at the end of 2019, we all started to become aware of this new virus, or new variant of the coronavirus that presented with a variety of fairly typical upper respiratory symptoms. But as time progressed, we started to realize that yes, some of the many of the patients recovered within weeks of their initial symptoms, but certainly many patients did not and had persistent symptoms over time. And we started to realize that there was another clinical phenomenon occurring here with this virus causing disease and symptoms for quite a lot longer than a typical cold virus would. And so, it's been given a number of names, and here's one of them, but post-COVID-19 first started to be identified sort of in 2020, and we have some initial publications characterizing the presentation of patients who had persistent symptoms. It's a challenging syndrome in that there's a lot of different names and a lot of different symptoms, and it's actually pretty confusing. And here are some of the names you've probably encountered. Post-acute sequelae of COVID-19 is a bit more of a research term. Some of these are patient names, in other words, names given by patients like long COVID or long haul COVID. Some of us have wondered whether, because of its similarities, whether we might also call it myalgic encephalomyelitis or chronic fatigue syndrome. But I think many of us have come to realize that it does seem to be a distinct entity with a different natural history, although I do wonder whether some of these individuals with long COVID will eventually just sort of turn into individuals with chronic fatigue syndrome with permanent disability. Hopefully that'll be a minority of patients, but we still don't really know what to expect. And then, of course, the other challenge of long COVID is just that it presents differently in different people. There are some common themes like fatigue and brain fog, but some individuals have a preponderance of mood disorder type features. Others might have more shortness of breath or respiratory symptoms that are predominant. So it's really very variable between individuals. And here is one of the other earlier publications that kind of looked to try to characterize what people were experiencing. So basically most of the organ systems really have been implicated in terms of people having post-COVID symptoms. So I think it's helpful to try to have to contain the diagnosis, and it certainly gives us some more confidence in applying that diagnostic label if we know how to define it, which is still a struggle, I would say. But the first one here from the CDC, they describe it as sort of post-COVID conditions being this umbrella term, and it's characterized by a wide range of physical and mental health consequences for people who have just contracted SARS-CoV-2 essentially. So as you can see, it's not exactly a very narrow label or a diagnostic description. And similarly, the NICE 2021 guidelines or NICE guidelines, again, similar in that they describe it as patients with clusters of symptoms, often overlapping, which can fluctuate over time and affect any system in the body. So really, both of these definitions kind of highlight the fact that it looks different in different people and can involve many different organ systems. I like this particular definition in terms of timeline because it makes sense to me and anecdotally in terms of what I've seen. So for those patients for symptoms up to the first 4 weeks, we would say that's, we can just blame all of that on acute COVID-19. Some individuals, have a bit more of a prolonged initial acute phase, and we might call these ones ongoing symptomatic COVID-19, where we feel it's mostly just the presence of virus that's causing symptoms. So that's sort of between the 4-week and the 12-week mark. But after the 12-week mark, everyone sort of seems to generally agree that that's the point at which we're kind of looking at, a post-COVID syndrome. So I like this framework. I think it's helpful and it's useful. We use it in the post-COVID recovery clinic to decide at what point we would accept referral. So and generally we tend to see people at the 12-week mark at the earliest, because we expect people in the first two categories that many of them will resolve and probably won't need our services. So yeah, early on when we started realizing that this was happening, there were a lot of worried people, and I think I continue to be worried about this, that a lot of people were not able to return to work and not able to return to work for a very long time. I certainly have patients who are at the 12-month mark who are nowhere near well enough to even carry out household tasks, let alone think about going back to work. And, the burden of disability is significant. There's some disagreement about exactly how many people have long COVID. And of course, that depends on where you draw the line in the sand. But certainly, this is probably a low estimate, I would say, that 10% of people after 4 weeks will still have ongoing symptoms. I would say it's probably even higher than that at the 4-week mark. I would say at the 12-week mark, it's probably close to 10% as well. So it's a large number of people. I've just updated these numbers. Who knows actually how many cases we have in PC right now? We really have no idea, do we? I rounded up from what the dashboard told me, but it's probably still underestimating it given our current Omicron situation. But let's just say if it's 10% of people, so far we've had 300,000 cases, we're looking at 30,000 people with persistent symptoms in BC alone. So, the economic impact and, not to mention the personal impact of many of these patients who are not able to get back to their normal lives. It's pretty significant. And I'm sure many of you have patients in your caseloads that are encountering this and dealing with this. So, I've just said that almost anything can be long COVID basically, but these are what we most typically see. So fatigue, brain fog, shortness of breath are, up there in terms of the top 3. Chronic cough, some individuals experience. Some people have chest pain, persistent chest pain. That's more like an atypical chest pain. Mood disorder, or either preceding mood disorder that's worse, or many patients no preceding history of mood disorder who now have mood disorder. Headaches also very common, and then the orthostatic or dysautonomia type symptoms like dizziness on standing, and then of course post-exertional malaise, which is why we kind of thought it looks similar to chronic fatigue syndrome. So these are the most common, but of course you'll see many other symptoms as well. I thought I would just run through a case that I saw here at the Post-COVID Recovery Clinic. She manages to kind of demonstrate many of the issues that patients encounter following COVID-19, and she's more of a severe case in terms of not really recovering. So this is a 47-year-old lady, previously very high functioning, like worked full-time as a nurse and also ultramarathon runner, and constantly training. So certainly an individual who was quite high functioning prior to contracting COVID in the spring of 2020. She managed her initial mild symptoms at home, as many of our patients do. And then she kind of pushed herself to get back up to her training schedule again and get back to work again. So, a few months later, after her initial infection, she started developing chest pain and shortness of breath. And so I would say she's a bit of an atypical long COVID case, in that her recurrence of symptoms occurred a little bit later than we normally see. But anyway, I still think that's what's going on here. So in August, she developed some cardiac symptoms. She was ultimately admitted at a hospital for a workup because her troponin was positive in the emergency room. And they did a fairly extensive set of investigations for her: echocardiogram, which was normal. She had a coronary CT angiogram, which didn't demonstrate any significant coronary artery disease. She also had a cardiac MRI for the possibility of myocarditis, which wasn't super normal, wasn't totally normal, but wasn't super abnormal. And then she had a CT chest, which, I think they were reaching to find anything abnormal. Again, not perfectly normal, but nothing really clearly wrong either. So frustrating for her. So really at this point, all we really have is a positive troponin and her symptoms. So essentially, at the end of the day, given the positive troponin, they said on the balance, it just makes sense to give her this label of myocarditis, and she was discharged. But had, again, these persistent symptoms typical of long COVID, so fatigue, post-exertional malaise. In her case, hair loss as well, which was very bothersome to her. And then, in terms of like the global impact, she was unable to return to work and has been unable to return to work as a result. She, because of her persistent dyspnea, was referred for respirology, and this was early on in our sort of long COVID experience. And so she got really a fairly full workup that we probably wouldn't do anymore now that we have a better sense of long COVID and what's sort of an appropriate workup. But at that time, she had full pulmonary function testing, which we would still do. That was all normal. She also had MIPS and MEPS measured, which were normal. She had a cardiopulmonary exercise test, which was normal, although, she is an ultramarathon runner. So obviously the interpretation of the results should be in the context of her previous level of cardiovascular reserve, but it was normal, although probably for her not what it once was. And then the repeat CT chest essentially was either unchanged or maybe improved from before. So essentially another more or less normal study. So at the end of the day, she has fairly significant shortness of breath, especially with exertion, but really on extensive investigations, no clear objective findings to explain why that was. And this is very typical for long COVID. We do all these investigations, everything comes back normal, and yet people are debilitated and unable to function. She also suffered from significant anxiety, and I'm sure this was multifactorial for someone who previously was a high functioning individual who is no longer able to run really, and not able to work either. So, but also, we see a lot of mood disorder following COVID, and it's unclear why that is, but it's a common finding. So we referred her to our psychiatry colleagues, and she was started on an SSRI with some benefit, and then counseling as well, which I think she found to be helpful, which was great. The hair loss, as I mentioned, very bothersome to her. Her ponytail was, according to her, basically non-existent compared to before. And you've probably seen this in your patients. This is a very common thing to see following COVID. And anecdotally, my experience, what I've noticed, it seems to be about 3 or 4 months after the initial infection, people start having massive hair loss. It goes on for somewhere between 3 and 4 or 5 months, and then it seems to kind of stop, and people eventually seem to settle out and have regrowth. So it's kind of, I guess, a little bit like similar to pregnancy hair loss, I suppose, but different in terms of the time course. So initially we were referring these patients to dermatology because we didn't know what was going on. We don't, probably not making that referral as often anymore now that we do. But anyway, in her case, she saw dermatology, and they made a diagnosis of telogen effluvium, and said that probably she'd have, that it would resolve over time, although not fast enough for her, and hers was quite prolonged compared to typical course. And they recommended topical minoxidil, which I think she tried without much success. So now this was the current update as of July. I haven't chatted with her since, but as of the, basically the 1.5 year mark, basically still unable to work, still shortness of breath with exertion, still post-exertional malaise, difficulty with sleep and mood, and brain fog. And she didn't feel like she was making a lot of progress. So again, this I would say is a more of an atypical case for long COVID. Most people, in my experience, do have improvement over time, although sometimes it's very slow, but most people do notice over time that they are slowly improving. This is where journaling is so helpful, because sometimes it can be hard to remember the progress that you've made as a patient. So I encourage people to document their, what they're able to do, what they're not able to do, and look back on it sometimes for encouragement, especially if their progress is slow. So essentially she's an individual, like many people with long COVID, with medically unexplained symptoms. I mean, I guess now we call it long COVID when we say it's medically explained, but investigations all look normal, but they have severe symptoms. And I just want to highlight that, I'm sure this is well known to all of you, but these are not, individuals with somatoform disorders. This is not just in their heads, although it could be brain dysfunction, of course, but this is not psychosomatic. These are, we believe there's a biological basis for their symptoms. It happens that our tools are too insensitive to pick up on them. So I guess it kind of begs the question, what is causing people's persistent symptoms if we can't measure them with the tools that we have, at least? And this is still unclear. There's a number of different theories, and it's probably multifactorial, probably different etiologies in different cases. But we think there certainly is evidence, for example, functional MRI imaging evidence of brain pathology or brain injury, for example, as a result of COVID-19, either from direct viral insult or perhaps immunologic phenomena. Hyperinflammatory state obviously is can be damaging as well. It may be that COVID-19 is particularly good at uncovering subtle immunodeficiency syndromes that otherwise we never would have known about. And of course, some people just have comorbidities and they're made worse with COVID-19. So those are some of the theories. We still don't really know. So this is my my overview of my general approach of how I think about, encountering a patient with persistent symptoms in the context of SARS-CoV-2 infection. So essentially what we're doing is completing a review of systems and symptoms, asking about the symptoms that we, see more commonly, and targeting our investigations to the patient's symptoms. So if, mostly their symptoms are respiratory in nature, then I'm going to be more likely to do a CT chest and those kinds of pulmonary function testing, those kinds of things, for example. I think after, a year and a half, or I guess, about a year and a half or so of time looking, seeing these patients, we've come to appreciate that exhaustive investigations are not required to rule out objective disease. And it's all the investigations, for example, that this patient had didn't really help us. I guess it helped us in that it ruled out other things. But essentially, if somebody presents to you with very typical symptoms of long COVID, then doing a basic workup to rule out other things, you can make the diagnosis on the basis of their symptomatology and the timing and from since they had their infection, and that's enough to make the diagnosis. So you don't need to do, extensive investigations and take 6 months to figure these things out. You can make a diagnosis in your office if the case sounds pretty typical. And it's important, because so many patients have this experience of getting test results, going for investigations and being told everything's normal. It's important to point out to patients that while your test results are normal, that's great. It shows that you don't have, that your cardiac function's normal, your lungs appear to be working relatively normal, but we still acknowledge that you were having these symptoms and that this impact of these symptoms is significant. So I think that's a really important point, because there is this disconnect. And if you have a patient who, their story isn't really typical for COVID-19, or there's something that's a little bit off, or you order a CT chest and there's actually objective findings of lung disease, and absolutely these patients warrant further investigations or potentially referral to subspecialty. But I would say that this is the minority of patients. So in terms of making the diagnosis, there's no checklist to say, if you have 5 of 8 criteria, you have long COVID. No, nobody's really done that yet. But so it's just good to get a sense. The more long COVID patients you see, the more comfortable you'll feel about this. But essentially, you're screening for the typical symptoms. And these are the ones in particular that you're going to be wanting to ask about. And then you can focus in on organ system symptoms as well. But brain fog, post-exertional malaise, profound fatigue out of keeping with exertion that isn't improved with rest. Sleep disturbance, and then in particular with long COVID, shortness of breath out of keeping with exertion really seems to be quite common. You don't have to rule everything else out to make the diagnosis, although you might want to do a workup in parallel, of course. And again, I've said this 17 times now, you don't need to do an extensive workup. So I thought I'd just focus on some of the typical investigations that we do. Most patients get labs. Labs are obviously a great way to screen for all kinds of organ disorder. And this is typically what we'll do. So, CBC, blood counts, electrolytes, liver, kidney function, lab screening for cardiac involvement, lab screening for iron deficiency, because obviously that's easily treatable, and thyroid, same thing. We were ordering a lot of D-dimers on patients, partly because of research protocol. And it's interesting how often this is positive. Early on, I think we were ordering a lot of chest imaging to look for pulmonary embolisms, which of course is associated with long COVID or COVID in general. But eventually I kind of, my D-dimer alert, I started ignoring after a while when I realized it just seems to be commonly elevated. I'm not sure that we really know yet why that is. It's of unclear significance. Are there microthrombi? That sounds certainly plausible, but most of these patients don't have clots. Of course, if they have a classic story, absolutely order the imaging. But I don't do D-dimers as a screening lab anymore, unless, I'm really trying to zoom in on that, because it's often elevated and then it's unclear what to do about it. Sometimes it causes more anxiety. I had one patient whose D-dimer, they were just tracking it over time. This is, again, early on, I wouldn't do this now, but tracking it over time, and the D-dimer went up over the course of 3 months. And this individual was quite anxious and worried about it. And so we decided in the end to order a VQ to avoid radiation. And the VQ scan was indeterminate. And and he was quite anxious about the possibility of clot. So I joke that this patient ended up on a DOAC for anxiety, essentially, which was not ideal. And probably never really had significant clot burden, but now ended up on rivaroxaban. So that didn't really feel like a win. And so anyway, all that to say, beware of D-dimers, they can be misleading. Respiratory symptoms. So functional respiratory investigations are super helpful, and we do these here in clinic. The sit to stand test, where you're essentially sort of going from a sitting to a standing position without using your arms a number of times in a minute. And there's normative data on the basis of age that you can look up. This is a great thing to do in your office, easy to do. We often send people for 6-minute walk test. Again, if you have a saturation probe and room in your office, you could easily do this as well, just to kind of get a sense as to whether people are desaturating or what their cardiopulmonary reserve is looking like. In terms of chest imaging, chest x-rays are quite insensitive to some of the changes that we see with COVID. And so if your suspicion is relatively high for pulmonary disease, it's worth just going to CT, I think. Of course, a bit more radiation, although not a lot more, but the chest x-rays just aren't all that helpful. Unless your suspicion is low and a chest x-ray is normal, and then I think that would be reasonable. Autonomic dysfunction, very common that people, where they're having essentially tachycardia occurring with changes in position. So postural orthostatic tachycardia syndrome. And so this is also fairly easy to make the diagnosis. You can actually get patients to measure their heart rates themselves at home. The best time to do this is actually often first thing in the morning. You get patients to measure their heart rate when they're lying down, and then get them to measure it again after they stand up at the 1, 3, 5, and 10-minute marks. And if you have anything more than a 30-point change from lying to standing, or if at any point the heart rate is jumping up over 120 just with changes in position, then that's enough to say that you're suspicious for dysautonomia. Other things can also cause this, right? So it's, obviously if you're hypovolemic, you might see this as well. So make sure that patients are well hydrated, et cetera, when they're, to rule out the other possibilities. If you are fairly convinced that they have a POTS type syndrome in association with long COVID, then our first line treatment is essentially hydration and salt supplementation. And often people feel much better even with this relatively easy, innocuous treatment. So it's a good place to start. Back to here again. So I just wanted to kind of focus on, when do you start thinking about, because I get questions about this, when do we refer to a specialist? And at the end of the day, it comes up to your comfort level with long COVID patients, and your sense of the illness script, and whether it is in keeping with what you feel would be a typical case. And it also will have to do with what access you have to subspecialty in the region that you work. I just wanted to draw your attention to one resource, which is the Rapid Access to Consultative Expertise, which is a service available Monday to Friday in BC by telephone. And there is a long COVID or a COVID sub race line, so you can talk to individuals with lots of experience in managing and diagnosing long COVID. So that's available to you Monday to Friday. So that's, I think, fairly helpful. If I have a patient who is pretty typical for long COVID, they had some screening investigations that are all unremarkable, and they tell me on history that they feel they're slowly improving, that to me is enough. And I wouldn't look to refer them on to another specialist. So that'll be the majority of your patients, I would say. here at the post-COVID recovery clinic, we typically will refer to other specialists if we have objective findings of end organ dysfunction, so cardiac or respiratory. I've had lots of patients with vocal cord dysfunction where they essentially lose their voice for months at a time. I've referred some of those patients on to otolaryngology, for example. Some patients have neurologic symptoms and we'll refer on there because that's a bit more atypical as well. We've seen lots of rashes, lots of exanthems in the context of long COVID or COVID-19. So we are lucky to have fairly rapid access to dermatology here, which has been super helpful. I had, I think, one case of a small vessel vasculitis in association with COVID. So anyway, all sorts of things that you see. And then, if I have a patient who's at the 9-month mark or the 1-year mark, who is profoundly disabled and really not making any progress, I started thinking about making a referral to the complex chronic disease program at BC Women's Hospital, which I'm sure some of you are aware of, which is a clinic that sees patients with fatigue and widespread pain, mostly with the view of diagnosing chronic fatigue syndrome and fibromyalgia and associated disorders. The reason I recommend referring there sort of at the 1-year mark and not maybe at the 2-year mark is that, as you probably know, there is about a 2-year wait list to get in to see the CCPP at the moment, which is far too long. So anyway, it's worth kind of being strategic and getting your referrals in earlier rather than later. Hopefully the patient improves and they don't need it. That would be the best case scenario. I thought I would share this just because I thought the CDC did a really nice job of kind of summarizing a lot of the stuff that I've said today, which is firstly that this post-COVID condition, or whatever label you want to call it, is an umbrella term for the wide range of physical and mental health consequences experienced by your patients, and that it's important not to only use objective lab or imaging findings as a marker of well-being, because often there's a disconnect. So, and I'm reiterating this, but essentially, if everything looks normal on paper, that doesn't invalidate their symptoms. In terms of treatment, what we really do is focus on specific symptoms, and there are other echo sessions addressing this far better than mine today. But essentially, we focus on symptom-based management in terms of treatment. And again, the final sort of humbling statement that we still don't really have a great understanding of the pathophysiology of long COVID. Just briefly, I'll talk about treatment, just to kind of summarize the main points. Really, pacing is key. Resting, recovering, allowing your sort of energy envelope to slowly expand over time is the key to success, and constantly trying to push past that and force your way through only really leads to setbacks. So it's important to, this is a really important piece of our messaging around management. And for some individuals who are used to being high functioning and pushing through the pain, this can be a very hard lesson to learn. If you have access to occupational therapy or individuals that can spend some time counseling patients around what it looks like to pace, that can be helpful, because it can be a very new concept or foreign concept for some individuals. This is sort of plan, pace, prioritize, another sort of way of thinking about this, and that you should plan how you spend your day. If you have this much energy, you need to be strategic about how you spend that energy. You need to prioritize what you do. You cannot do everything. So what are the 3 things that you really need to do or really want to do? And again, that might be a new way of thinking for some people. Pharmacotherapy, as you know, nothing to date really has been proven to be all that particularly effective in terms of shortening the duration of long COVID. Lots of ideas out there about what might be helpful, including a number of over-the-counter supplements and vitamins. We don't know if they're helpful or harmful or have no effect. That said, I think, some supplements are potentially helpful. And I think taking supplements for some people gives them a sense of control, like they're actually doing something to treat their symptoms. And I don't think that's wrong. So, but anyway, there's no evidence, of course, to support any of that, but that's sort of my pragmatic approach to things. A lot of your patients will have been off work and are thinking about getting back to work again. So essentially, you want to do this in a measured, paced approach. Consider referring to a multidisciplinary team. If they got COVID-19 at work, then absolutely make a referral to WorkSafe BC, who have a post-COVID clinic of their own and access to services. Provide written information or access to resources. And I generally tell patients that, most patients do get better. We don't know how much better everyone will get, but we do know that most patients will probably get better over time. And so I think it's important to kind of give people some hope that they will get better, although it might be at a much slower pace than they had hoped. And finally, just some websites that I find that I use a lot that I find particularly helpful. The NHS has some really great patient-facing information on long COVID. The CDC just has a nice, easy interface. This is the PHSA, Post-COVID Care and Recovery website. And then again, the RACE, which I already mentioned earlier. And yeah, I think we have some time for questions, discussion.
Thank you so much, Renee, for such a great presentation. Yeah, so if everyone with their questions and discussion points, if you could use the raise hand function at the bottom of your Zoom, or you can pop them into chat. Yes, Greg, I see you have a question.
Yes. So the case study that you presented is similar to many of the case studies that I've seen for long COVID, where it always seems to involve somebody who is previously fit, ultra marathoner, personal trainer, a very active person, and they make for compelling case studies because of the contrast between their previous life and their current presentation. The question arises, though, is the common thread in these patients the strain to their myofascial tissues, and is this something that you see in a wide assortment of the patients you see, that they've had history of myofascial injury or strain, whether they're a dancer or a rower or engage in other forms of recreational activities?
Yeah, good question. I've had the same thought that, I mean, maybe it's like you say, that the contrast is so memorable that you kind of flag it in your mind. But I have anecdotally had noticed that it seems that there are a lot of people who are used to pushing themselves very hard beyond what most of us do. Is that somehow a risk factor, for example, in having worse long COVID? Or is it just that their usual strategies in coping, that they're pushing themselves as they're recovering, pushing themselves too quick, too early, and that they're actually contributing to their slow recovery? I mean, I guess there's no real way to know, but I've noticed the same thing. That said, of course, I have other examples of patients who weren't ultra marathoners who also had long COVID. So yeah, I guess I don't really have an answer for you other than I've noticed the same thing, and I do wonder about it. And I think certain people just have a pattern of, some people are really good at ignoring those internal stimuli or internal voices that tell them to stop. I think there's signals that their brain telling them to stop. So maybe that's ultimately harmful in these individuals and leads to them having worse disease. I don't know. It's hard to say. It's chicken or egg, I guess.
Well, here's a consideration in that we know that COVID is affecting the body because of the ACE2 receptor. And ACE2 receptors are in high concentration in many of the organs of the body and less so in myofascial tissues. But if you consider that myofascial tissues constitute 50% of the body by mass and skin 15% of the body by mass, so 2/3 of the body is soft tissue that has, albeit a lower concentration of ACE2 receptors, but nonetheless constitutes such a large portion of the body that may be the source of many of these constitutional symptoms affecting exertion, whether in ambulation or in breathing or any other movement of the body, that perhaps the source of it is soft tissues.
Yeah, I mean, that makes sense to me.
Thanks for that, Greg. That's a very interesting point. I just have another question here, Renee, in the chat. Is there any predictability who might suffer from long COVID in those with more severe symptoms during COVID infection? Like, would those patients with milder symptoms have less tendency to develop long COVID?
Oh,
So just a
yeah,
question
I had
about phenotypes.
Yeah, sorry, I had a slide on that and I wonder what happened to it. I just realized I didn't see my slide, which I thought was in there, but yes. Female, so there are some sort of features that predict worse outcomes, and it's female, older age, obesity, asthma, or kind of some of the more common, the ones that have been sort of shown to be more associated. But I would say, again, this is maybe a little bit more, anecdotally, our sense has been that it's been a lot of people with mild initial symptoms who've had long COVID, more so that they've been overrepresented compared to those individuals who perhaps required hospitalization. So that said, of course, if you had severe hospitalization, require ICU stay, then you get into a whole bunch of other issues that you would expect people to have sort of persistent symptoms over time. So, but our general sense is that individuals with mild symptoms initially are overrepresented in terms of experiencing long COVID. But at the end of the day, I don't think we have a great algorithm for predicting who's going to do well and who's not going to do well. At this point, we don't have great tools to predict.
Thanks for answering that. Another question from the chat here. Are there any statistics on differences in patients who are vaccinated versus unvaccinated in regards to long COVID symptoms?
That's such a great question. As I was preparing this and updating this, I was looking for the answer. I don't know if we know that yet. Are you less likely to have long COVID if you've been vaccinated and then get COVID? I don't know that we know that yet, but that's a really great question. I sure hope so. I mean, I think there were some, I believe there was one publication where it looked like the incidence of long COVID was slightly less in individuals who've been vaccinated, but I don't think we have great big data on that just yet, unless someone knows otherwise, but that's my understanding. But I hope so.
I hope so too. It's evolving, I'm sure. Another question from the chat is, I was unaware of the WorkSafe clinic. Thanks for that information. How is it determined that a case was work-related? Given our lack of testing, tracing, and I suspect many people would get COVID at work and not know the source. Is there something workers should be doing to ensure that it is considered when they can get tested?
Oh boy, that's a multifactorial or a multifaceted question if I ever heard one. Yeah, so firstly, WorkSafe BC will consider cases on a case-by-case basis. So if there was a known outbreak and an individual was working there, then that's usually enough for them to say that the claim would be accepted. Or if there was a known contact at work and then that person was exposed to that individual, even if they had exposures potentially elsewhere, that would, I think, on average, be probably enough to have an accepted claim. Yeah, I mean, it's tricky now with Omicron because of how widespread it is. I don't know if their policies will change or how they will trace or track when we don't even really have a good sense as to who has it when because of our inadequate or our lack of testing. I won't get into the politics of that, obviously, but I think the best thing to do is if the patient contracts COVID and there's a suspicion that the possibility could exist that they might have gotten it at work, then I would say it'd be reasonable to apply for a WorkSafe BC claim. They would assess it, and my sense is that they're relatively willing to consider the possibility and err on the side of allowing a claim is my sense.
Great. That's very interesting. I'm just going to call on you, Jill. You got your hand up there.
Yeah, I just wanted to speak to the myofascial thoughts. My thoughts that I'm hoping someone will study is the effect on the nervous system or the autonomic nervous system, because I think there's a bit of traction of symptoms around POTS and around effort to breathe or breathlessness that has to do with the sensation rather than the function of the lungs, the heart, and so on. So the feedback the body is getting is an alarm bell when in fact the signals are not actually accurate for that. So I think that's one category of patient I'd like more scientific help on. I am getting my patients with breathlessness to do a resistance training with tubing so that they can gradually get used to breathing through resistance. And so breathing without that in the way starts to be perceived as okay and normal for them. So that's something I've added to the breathlessness workup that we have on the PHSA website. The other category of patient that I want to throw in the loop are, instead of just long distance ultra marathoners and the physical people that are obviously expecting a lot of themselves, I have quite a catch of my nursing colleagues who've been exposed, and nurses in general are very, very smart people with huge amounts of cognitive demand for them to do their jobs. And I've been having a lot of my colleagues, even though I'm sort of retired, just asking a favor consult from me to give them strategies to perform at the previous level that they needed. One gal from our gastroenterology suite, she knows everybody's penchants of what they want for them to do their job. So the physician just walks in and she has this library of mental capacity that she's missing, and she really misses it. So I've had to teach her how to subdivide her job down, give herself little visual prompts, makes little piles of paper or whatever, all the strategies that I use anyway, because I'm not as smart as her. I've told her my tricks and she's starting to use them. So I think that's where we have a catch of patients who are the physical complaints, but there's a huge ballast of the cognitive acumen just being a bit off, cognitive brain fog, and needing to resign themselves to using some of the strategies to help out.
Thanks, Jill. Those are great points.
Very interesting.
And I just want to mention on that point, we did do a previous echo session on neurocognitive rehab, because I think with this Omicron wave, we're going to see more and more pronounced brain fog, as this is really affecting the age 45 to 60 working professionals. So I think that's a good one to look back to on different strategies and homework you can give your patients, like little bits at a time, to do some cognitive rehab. There's just another question in the chat here. Is there enough information yet to determine which COVID variant results in long COVID?
Oh, that's interesting. I mean, as far as I'm aware, they all have been. I'm not sure if we know numbers in terms of which is more associated than another. And partly that's just limited. I mean, here at St. Paul's, we're able to test to see which variant, but in other facilities, you don't have that information. So it would also be probably tricky to gather that information. Of course, you could probably infer which variant it was from the time period, I suppose. And I'm sure there are I know there are other parts of the world that do more testing to see which variants. Obviously, you'd need that information, but as far as I know, they are all associated. Is one more associated than another? That I don't know.
Great. Just before you, Greg, there was one more question in the chat. What is the rate of long COVID in children? Is asthma also a risk factor for an increased risk of long COVID in them as in adults?
Oh, I had pediatric questions last time, and I have to say the same answer, which is that I'm a bit ignorant about the pediatric long COVID, although maybe there's someone else here that might be able to speak to that. I think last time there was, but I'm not aware of I don't know the answer to those questions, unfortunately, because I just work with adults.
Would anyone here like to speak to that? Or read anything about the pediatric asthma being a precursor to long COVID? Okay, sure we can.
Jill Calder here. I don't think that anecdotally it is specifically a precursor in the COVID pediatric that I'm overlapping with. I'd say I've got about 10 or 12 so far of the pediatric catch, and they don't seem to have pre-existing asthma as a risk factor.
Okay, great. Thanks, Jill. Greg, you had your hand raised. Do you have another question?
I just wanted to comment on Jill's the topics that Jill raised, and I've had some success with treating patients who have chronic pain and have POTS by addressing the myofascial strain to the tissues overlying the carotid sinus and carotid body. So by relieving the pressure and strain that exists within the platysma and anterior scalene, it often contributes to a change in their POTS symptoms. And similarly for brain fog, I've had many patients who've benefited from addressing scarring on the lower third of their face or around their mouth and chin. And over our lifetimes, it's very common to develop scarring of the soft tissues around the mouth and chin as a result of cystic acne scars or falling, a laceration on the chin from falling, or injuries to the lips or mouth. And addressing those scars seems to change the tension that exists within the around the mouth, which has an impact on
Greg, thanks for sharing that. I'm just being cognizant of time. We have 5 minutes. I just wanted to, we possibly have time for one more question, but just a few last sort of housekeeping I wanted to remind everyone. So first of all, thank you, Dr. Jansen, for this incredible presentation. It's so important to come back to these fundamentals, and we're really wanting to support all these healthcare workers as they continue to care for these patients in recovery. We're hoping that this session helps you do that. There will be a post-event survey form that will be sent out to all participants after this session. It is brief. It will take maximum 2 minutes, but we really want to ensure that this content is meaningful to your practice. And so if you could take a minute to fill that out, that would be really helpful to us as a hub committee. And just as a last reminder, our next ECHO session will actually be in March. It will be held on Tuesday, March 8th from 12 to 1. So look out for that topic and registration online to come soon. We are regrouping in February to review with our family physician partners just to finalize content and curriculum for our next sessions. And so thank you again for attending today, all of you, and I hope you continue to stay well, caring for yourselves and family and your practice. And we have just 3 minutes here. If anyone has some last comments or questions for each other, our panel, or speaker. Yeah, everyone's thanking you, Dr. Jansen, in the chat, saying how amazing it was. So
Great.
Thank you so much for your time and your expertise today.
Oh, yeah, most welcome.
Okay, wonderful. Have a good day, everyone. Take care.